Hi, good afternoon, everyone. Today, first of all, I would like to thank you, Dr. Yankelevich and Dr. Hensky, for giving me this big opportunity to talk today. Today, I'm going to talk about digital tomosynthesis. And for the 7 minutes, I'm going to cover about accuracy of digital tomosynthesis and lung cancer screening. It's easier because I'm talk after the special session, so I'm gonna go fast for the beginning of. So digital tomosynthesis is a limited angle tomography technique that construction continuous in coronal section, and it can enhance nodule conspicuity and reduce anatomical overlap, offer improved visualization of lung parenchyma. This is like a sample of digital tomosynthesis that you can see from the front into the back. So you can see the lesion in the soft tissue bone and then into the lung lesion and also the structure. And for the accuracy of digital tomosynthesis, the study showed that the DT is as sensitive as CT for detect actionable lung nodules, as it can reach 100% sensitivity with the size of nodule 6 to 8 millimeter, while chest X-ray only 27%. And let's look at the detection sensitivity by maximum LLF. This is gonna see that for the overall lesion that size 3 to 20 millimeter, DT can detect 3.6 times higher than chest X-ray, and the magnitude is reached maximum at 7.5 times higher at the lesion size 4 to 6 millimeter. Here are the systematic and meta-analysis review of digital of 16 study compare digital tomosynthesis and chest radiography. And it shows much superior of sensitivity and specificity of digital tomosynthesis than chest radiography, like a sensitivity of 0.85 and specificity of 0.95, while chest X-ray only 0.47 and 0.37 specificity. And also when look at the lesion-based detection rate, the study that include patients with pulmonary nodules and without pulmonary nodules, the risk ratio of digital tomosynthesis is about 2.9 times higher than chest radiography. And when look at the radiation dose, the dose of DT is approximately twice higher than chest radiography, but much smaller than CT. This study showed the use AI-based computer-aided diagnosis for chest radiography and chest digital tomosynthesis. It also showed that AI-based digital tomosynthesis have a higher performance, higher accuracy and sensitivity in detecting pulmonary tuberculosis and pneumonia than chest X-ray-based AI CAD. Now moving on to the lung cancer screening. This study is from Italy. SOS study group used digital tomosynthesis as a screening tool, and among heavy smoker. For nodule 5 millimeter or larger, they're gonna do low-dose CTs. From this study, they show that 7.2% has lesion need CT scan, and the lung cancer detection rate is nearly 1%, that comparable to the international study. However, the stage 1 lung cancer is quite low than Nelson, and in LST it's just 44.4%. And adenocarcinoma is 54%, 5% and squamous cell 39%. Here again, look at the sensitivity is show the good sensitivity of 5 to 8 millimeter compared to CT as a reference standard, and chest X-ray is only 19%. And for this one, the nodules apparent here. We can see that there are no difference between nodule appearance like a peripheral nodule and also gallglass nodule that before maybe have mentioned that maybe is not good in detect gallglass nodule, but study show that no difference between nodule appearance as described by digital tomosynthesis and CT. And when look at the ROC curve to classify nodules according to Langlat into 5 categories, the DT has the ROC of 0.8 and CT 0.89. That's quite good. This study shows using the digital tomosynthesis for evaluating metastasis lung nodules. This study, the mean nodules quite low, is just 3.9 millimeter. And they just found visible nodule in DT only 53%. And the mean size of detect nodule is 8.6 millimeter. However, the proportion of malignant to visible nodules on DT was significantly higher, 64.7% higher than CT, that 41.1%. And the common reason of false positive finding on DT is the vessel lesion in the central and peripheral post-op scar and bony lesion, and also the subpleural and pleural change. For the common false negative finding, most of case in this study is size lower than 5 millimeter. And for the size that larger than 5 millimeter, the lesion is in 2 central and also far basal location. Now, this is the last study from Thailand that use integrate low-dose digital tomosynthesis into the low-dose CT. Use alternating digital tomosynthesis and low-dose CT, begin with low-dose CT for those who have normal low-dose CT lesion, and also after follow-up for 2 years and the lesion stable. So this study showed that the overall lung cancer detection rate is around 0.8%, while Nelson and NLST 0.9%. However, when look at the stage 1 lung cancer rate across low-dose CT trial, our study is 50%, while the other is, so it looks comparable with other international study, but higher than Nelson that use the interval longer than annual. So my take-home message, digital tomosynthesis for lung nodule detection, the diagnosis performance is effective in detecting actionable lung nodules 5 millimeter, larger than 5 millimeter. And chest X-ray is markedly inferior to digital tomosynthesis. The main limitation of missed nodules on DT is small size, 5 millimeter or lower, and the lesion of invisible of nodule more than 5 millimeter is central location and far basal position. For the frequent mimics, false positive finding include the central vessel bone lesions, subpleural or pleural change, and post-operative scar. Implication for resource-limited setting DT is a promising alternative to CT for lung cancer screening, where resources are constrained due to the lower cost, reduced radiation exposure, and superior detection compared to chest X-ray. Thank you.